My talk is on ocular surface management in cataract patients. Ocular surface disease is more common in elderly individuals that frequently require ophthalmic surgery that further compromise the ocular surface by injuring the epithelium, sensory nerve, disrupting the tear film and causing the further local inflammation. And ocular surface disease can be broadly classified either in a non-visually significant or visually significant. In non-visually significant, surgery can be proceeded as planned, and we should counsel the patient about the potential for worsening after the surgery. But in visually significant ocular surface disease, it affects the preoperative measurements like topography, keratometry, refraction, aberrometry, and which affects the potential post-operative surgical outcome. So in this type of visually significant OSD, we should sufficiently treat these conditions prior to surgery, convert them in non-visually significant, and then proceed with the surgery. Because failure to manage ocular surface disorder can lead to the unsatisfactory vision, worsening of the symptoms, and it can also cause the infections like the endophthalmitis. So medical management of the OSD prior to ophthalmic surgery is very important. And among all the OSD, dry eye disease is very important. Patient may present with the blurry or fluctuating vision, so we should treat the dry eye effectively before the patient has any type of refractive or cataract surgery. Although most patients with dry eye may be asymptomatic, 87% of the cataract surgery patient become symptomatic after the surgery. Dry eye disease or OSD affects the topography, biometry, keratometry, higher order aberrations, and it causes the disappointment in the post-operative outcome. Even the cataract surgery also causes the dry eye via the various mechanisms like the use of topical eye drops with or without preservative, phototoxicity, intraoperative sterilization with the povidone iodine solution, transaction or denervation of the nerves, increase in the inflammatory markers, and the loss of the goblet cell density. So dry eye adversely affect the outcome. So in the preoperative period, we should diagnose and manage the dry eye disease. For the management point of view, sometimes the preoperative diagnosis, patient history is very important. Patient may give the history of grittiness, discomfort, blurry vision, fluctuating vision, or there may be history of some systemic collagen vascular disease. So we should look out in the preoperative period. On the clinical examination, you can find the debris in the tear film, a low tear meniscus height, evidence of the lid margin disease. On performing the fluorescent stent, we can find out this SPKs or superficial punctate keratopathy that we can miss in the normal slit lamp examination sometimes. Corneal sensation, especially in a diabetic patient, there may be chance of persistent epithelial defect in the post-operative period. So in the suspicious patient, we should look for the corneal sensations also. And in the management point of view, because of the elective nature of the cataract surgery can be postponed till the surface can be optimized. And for the surface management, artificial tears are very important. Nowadays, especially cyclosporin can be used in the preoperative period because it decreases the chance of steroid-induced side effects. In cases of the aqueous deficiency dry eye, after controlling the ocular surface inflammation, we can use the punctal occlusion. Another ocular surface disease which is very important in the cataract patient is the meibomian gland dysfunction that causes the evaporative type of dry eye disease. Even the epithelial basement dystrophy can cause irregular astigmatism and the blepharitis. That also affects the increases the chances of the ocular inflammation and increases the chances of the infection in the post-operative period. So management of the lid disease in the preoperative period is also very important. It starts with the eyelid hygiene. Topical azithromycin decreases the chances of the signs and symptoms of blepharitis, and in severe case of the flactellus or severe conjunctivitis, topical antibiotic steroid can be used. Even sometimes use of tetracycline at least 1 month before cataract surgery can be done, and omega-3 fatty acid is also beneficial in the management of the lid diseases. Even after the post-operative period, management of the ocular surface disease is also very important in the especially artificial tear solution. We can use preservative-free or eyelid cleansing should be continued. But in the patients with the surface disease, it is best to stop or taper the medication when it is no longer needed, especially topical NSAIDs. In the cases of the epithelial breakdown, theoretically it increases the chances of the corneal melt. So in conclusion, the overall goal is the preoperative ocular surface disease management include reducing the inflammation, resolving infection, improving pathology, stabilizing the tear film, and easing the symptoms before the surgery, which increases the likelihood of the positive outcome. Thank you.
Thank you, Dr. Rishi. And it's really very essential to, treat the ocular surface, particularly wherein you are planning to implant a premium IOL, the multifocals and the EDOFs, etc., wherein the results may be adverse if the ocular surface